Welcome to Medical Specialists Associates' educational series educational series on pain and addiction medicine. I'm Christopher Voss, MD, MS, FCCP, a board-certified pain medicine and addiction medicine physician. Today, we'll be discussing ALTO, alternatives to opioids. As healthcare providers, it is crucial to explore safer, evidence-based alternatives for treating pain, especially in light of the ongoing opioid epidemic. Every day, approximately 130 Americans die from an opioid overdose. This alarming statistic underscores the need to reconsider how we manage pain in our healthcare system. Opioids, while effective, are now considered a third-line treatment for many pain pathways due to their high potential for addiction and overdose. The ALTO, Alternatives to Opioids program, was developed to address this challenge by shifting the focus toward non-opioid treatments that are both effective and safer for patients. Musculoskeletal pain. First-line treatments. Non-opioid options such as ibuprofen, cyclobenzaprine, and diazepam are recommended as first-line treatments for musculoskeletal pain. These agents work by reducing inflammation and muscle spasms, providing relief without the risks associated with opioids. Ibuprofen, 400 to 600 mg every 6-8 hours as needed. Cyclobenzaprine, 510 mg 3 times daily. Diazepam, 210 mg 2 to 4 times daily. Second-line and alternative treatments. Ketorolac and dexamethasone are effective second-line agents, while lidocaine injections, regional nerve blocks, and oral gabapentin or pregabalin are valuable alternatives. Topical NSAIDs like diclofenac gel and lidocaine patches can also provide localized pain relief. IV lidocaine has anti-hyperalgesic and anti-inflammatory properties, making it a viable opioid substitute. Ketorolac, 15 to 30 mg 4 IM every 6 hours as needed. Dexamethasone, 4-8 mg IV IM once daily or as needed. Lidocaine injection via trigger points. 1% lidocaine, 1-2 ml per injection site. Lidocaine patch. Apply 1-3 patches to the affected area daily for up to 12 hours. Topical NSAIDs, diclofenac gel. Apply to the affected area 2-4 times daily. Gabapentin 300-600 mg orally 3 times a day. Pregabalin 75 to 150 mg twice daily. Lidocaine infusion, 1 to 1.5 mg kg as a bolus, followed by an infusion of 1-2 Angimin. Regional nerve block, administered based on the specific nerve involved, typically under ultrasound guidance. Headaches and migraines. First-line treatments. For headache management, ibuprofen, acetaminophen, and sumatriptan are effective options. Sumatriptan, in particular, is useful for migraines, working by constricting blood vessels and reducing inflammation. Ibuprofen, 400-600 mg every 6-8 hours as needed. Acetaminophen, 500-1000 mg every 4-6 hours as needed. Sumatriptan, subcutaneous, 6 mg subcutaneously. May repeat after 1 hour if headache returns. Second-line treatments. Medications like ketorolac and dexamethasone, along with antiemetics such as prochlorperazine, can be utilized if first-line treatments are inadequate. Ketorolac, 15-30 mg IV IM every 6 hours as needed. Dexamethasone, 4-8 mg IV IM once daily or as needed. Prochlorperazine, 5-10 mg orally every 6-8 hours as needed. Diphenhydramine, 25-50 mg orally every 4-6 hours as needed. Magnesium IV, 1-2 G4 over 20 minutes as needed. Alternative approaches. Sphenopalatine ganglion blocks with bupivacaine and cervical or trapezius trigger point injections with lidocaine offer targeted relief for specific headache types, further reducing the need for opioids. Atarax, hydroxyzine, and capsaicin cream may also be considered for managing chronic migraines and associated symptoms. Bupivacaine, sphenopalatine ganglion block, 0.25-0.5% bupivacaine, typically 1-2 ml per nostril. Lidocaine injection, trigger point, 1% lidocaine, 1-2 ml per injection site. Atarax, hydroxyzine, 25-50 mg orally every 6-8 hours as needed. Capsaicin cream can be used intranasally to help reduce the frequency and severity of cluster headaches by depleting substance P, a neuropeptide involved in pain transmission. Fracture and joint dislocation. First-line treatments. Acetaminophen and intranasal calcitonin serve as primary interventions. Ketamine, administered intravenously, has been shown to provide analgesia equivalent to that of morphine, but with a better side effect profile. Acetaminophen, 500-1000 mg every 4-6 hours as needed. Ketamine IV, 0.1.3 mg kg IV for pain. This dose can be repeated as needed for analgesia. Intranasal calcitonin, 200 IU administered intranasally, 1 spray. Second-line treatments. When first-line options are insufficient, IV ketamine can be continued, and intranasal calcitonin may be supplemented with other non-opioid pain management strategies. Topical NSAIDs, lidocaine patches, and regional nerve blocks may also be considered. Topical NSAIDs, diclofenac gel, apply to the affected area 2-4 times daily. Lidocaine patch, apply 1-3 patches to the affected area daily for up to 12 hours. Regional nerve block administered based on the specific nerve involved, typically under ultrasound guidance. Abdominal pain. First-line treatments. For abdominal pain, metoclopramide, prochlorperazine, diphenhydramine, and dicyclamine are effective in managing pain and associated symptoms such as nausea. IV lidocaine has emerged as a potent alternative for managing acute pain in cases where opioids are not desired. Metoclopramide, 10 mg IM orally every 6 hours as needed. Prochlorperazine, 5-10 mg orally every 6-8 hours as needed. Diphenhydramine, 25-50 mg orally every 4-6 hours as needed. Dicyclamine, 20-40 mg orally 4 times daily. Lidocaine infusion, 1.5 mg/kg as a bolus followed by an infusion of 1-2 mg min. Second line and alternative treatments. Haloperidol and lidocaine infusions are also valuable in managing complex abdominal pain scenarios. Lidocaine particularly has shown promise in gastrointestinal surgeries for reducing pain scores and opioid consumption. Topical NSAIDs and capsaicin cream may also be considered for specific types of abdominal pain. Haloperidol, 1-2 mg IM every 4 to 6 hours as needed. Ketamine IV, 0.1-0.3 mg/kg IV for pain. This dose can be repeated as needed for analgesia. Topical NSAIDs, diclofenac gel, apply to the affected area 2-4 times daily. Capsaicin cream, apply a thin layer to the affected area 3 to 4 times daily. Renal colic. First-line treatments. Non-opioid treatments like normal saline, acetaminophen, and ketorolac are effective in managing the intense pain associated with renal colic. Normal saline, 500-1,000 ml IV bolus followed by maintenance fluids as needed. Acetaminophen, 500-1,000 mg every 4-6 hours as needed. Ketorolac, 15-30 mg IM every 6 hours as needed. Second-line treatments. Lidocaine infusion offers a novel approach, with evidence suggesting its efficacy in reducing pain while avoiding opioid use. Desmopressin, administered either intranasally or intravenously, can also help manage pain by exerting an anti-diuretic effect and relaxing smooth muscles in the renal pelvis and ureters. Lidocaine infusion, 1.5 mg/kg as a bolus followed by an infusion of 1-2 mg min. Desmopressin, intranasal or IV, 10-40 mg/g intranasally or 1-4 mg/g4 depending on the severity of symptoms. Topical NSAIDs, diclofenac gel, apply to the affected area 2-4 times daily. Conclusion. The ALTO program, combined with these recent advancements in non-opioid pain management, provides a robust and scientifically validated framework for reducing reliance on opioids. By integrating these alternatives into clinical practice, we can manage pain effectively while minimizing the risks of addiction and other opioid-related complications.